At the outset, I would like to thank the team IDCM, in particular Dr. Akash Singh and the entire team for inviting me on this very important podium and a very important, interesting session. We are going to have a panel discussion on pregnancy and diabetes, controversies and updates. So this is a very interesting topic. Because if we see, pregnancy is associated with changes in insulin sensitivity, we know that. And this leads to changes in the plasma glucose level. Basically, in pregnancy, the mother tries to adapt to the increased nutritional requirements of the fetus as well as of the mother herself. And because of this, there are an entire list of physiological changes which occurs in the mother, leading to various alterations in the metabolism. Prevalence of hyperglycemia during pregnancy has been steadily increasing with the rise of obesity and type 2 diabetes. As we know, type 2 diabetes and obesity are increasing, so hyperglycemia during pregnancy is becoming more and more of a problem. The risk of adverse pregnancy outcome increases continuously with increasing glucose levels. So whether the patient falls into the GDM range or not, it has been found that if there is hyperglycemia, it continuously increases the worse outcomes as compared to what would have been if the levels were a little lesser. Maintaining the glycemic target reduces the maternal fetal complications. This is absolutely well defined by studies. So this is what our target remains. Now, what is the problem with pregnancy and diabetes is that hyperglycemia in pregnancy is that there is a significant variability in care. The variability in care for GDM is due to a lack of consensus. And there are no definite professional society guidelines. Every society has a different set of guidelines and a clinician does not know what to follow. There is a difference in the optimal screening, in the diagnostic criteria, in the treatment, in the post-delivery screening as well. Why should we know about the pregnancy and diabetes? Because we know the effects of hyperglycemia on the fetus, large for gestational age, macrosomia, respiratory distress, neonatal jaundice, neonatal hypoglycemia, polycythemia, hypocalcemia, hypomagnesemia, shoulder dystocia, difficult labor, and so on and so forth. In maternal preeclampsia, gestational hypertension, birth trauma, requirement of cesarean section many a times, and increased risk of developing T2DM in the later life as well. So there is a list of complications of hyperglycemia on pregnancy, hyperglycemia in pregnancy during the pregnancy, as well as then we are having the challenge of long-term complications also. So a mother would develop probably she has a higher chances of developing type 2 diabetes in later life, and the child who is born to a mother who had gestational diabetes would have a higher chance of having diabetes as well as obesity in life. Now coming to a case presentation, we have a 31-year-old woman. She's a teacher by occupation. She's referred from the obstetrician because at 20 weeks of gestation of pregnancy, she was seen, her BMI was 25, her BP was 124/78. She did not have any significant past medical history. But her family history was showing a strong family history of both her parents being diabetic. The obstetrician had conducted a 75 gram oral glucose tolerance test, and what they found was that fasting plasma glucose was 106 and the 2-hour value was 138. So now what do we do? What do we say? What is she a case of? So the screening and diagnosis. The first part, if we see the screening and diagnosis, this also has a lot of controversies. Why do we want to screen? We want to screen because we want to identify asymptomatic pregnant women at high risk of developing GDM. Because this is a very cost-effective method for preventing obstetrical adverse outcomes as well as long-term sequences of GDM. So very simply we can avoid a lot of complications in the mother as well as fetus, and that is why we want to have identify these GDM cases as early as possible. But there are a large number of controversies. Who to screen, when to screen, and then how to screen, which criteria to apply. So coming on the first part, who to screen? The population to screen has as yet not been uniformly identified. Some schools of thought say it should be a selective screening only for the high risk women. Whom do we consider high risk women? Women who are of more than 25 years of age, who are of ethnic origin, they are Hispanic, African, Native American, Southeast Asian or Pacific Islanders. So Indians fall into this ethnic origin group. So Indians have a much higher occurrence of GDM. If the Western population shows a prevalence of around 7 to 10%, Indian population shows in the urban setup to around 13 to 17%, a very high occurrence of prevalence of GDM. So because we are in the ethnic origin, the BMI more than 25 and a past history or family history of impaired glucose tolerance any time in the life or anyone in the family, and any history of macrosomia or adverse obstetric outcome, of history of any congenital abnormalities in the previous babies, all these are the high risk group. So one school of thought says that you screen only for this high risk group as a routine. But the other group, school of thought says that we should have a universal screening where all the women should be subject to screening. So especially where countries where overweight and obesity are widespread health problems, it's better to go in for a universal screening. But still we don't have any consensus in the guidelines given by the societies. Now the important question, when to screen? So what is the right time to screen? So as per the guidelines, when the women with risk factors, high suspicion, then you should have a screen on the first prenatal visit, when the lady comes to you first. If you have got her as diabetic, fine. Otherwise, you repeat it at 20 weeks, 26 weeks, and then 30 weeks. Otherwise, you can screen at around 24 to 28 weeks. That is a must. But otherwise also, if you feel, we can screen earlier on. Then, how to screen? Now, how to screen is one very important aspect. There have been a lot of studies which had a one-step versus a two-step approach. And there's a very important study, the hyperglycemia and adverse pregnancy outcome study, HAPO study, which looked into a very large number of patients, 25,000 pregnant participants, and they tried to define a threshold of what should be the cutoff when we should call it a GDM. So they did a one-step approach at 75 gram oral glucose tolerance test in pregnant women, 24 to 32 weeks of gestation. And what they found was there was a linear association between the maternal glycemic levels with both maternal and fetal outcomes. But the threshold as yet was unclear on the basis of HAPO study only. So following this, the American College of Obstetrics and Gynecologists, what they did, they had a meeting on this and they said that there was no enough data to support intervention at this lower cutoffs. And there were significant healthcare delivery implications of diagnosing more cases. So you got to have more cases, but probably not much advantage of treating it. That's what the ACOG says. The NIH also said the same. So they still accept a two-step approach. But then on the basis of this HAPO study, the IADPSG, the International Association of Study of the Diabetes in Pregnancy, they made a cutoff that we will be showing, and most of the associations approve a one-step approach. What is the advantage of one-step approach? Identifying more pregnancies which can have adverse outcomes. Two-step may miss the patients at the similar risk because lesser number of patients got, so probably we may miss sometimes. And if we look into the cost effectiveness, if we go by the one step, we are having a larger number of patients, we are preventing 85 cases of shoulder dystocia, 260 cases of preeclampsia and 688 cases of future diabetes per every 100,000 pregnancies. That's a good number. So, and it's very, very well accepted. So, many of the associations approve it, but sometimes some associations like ACOG says that data are lacking whether treatment is going to improve the outcome and the cost is increased. These are the guidelines, 75 gram by the IADPSG. which shows that fasting threshold more than 92, 1 hour more than 180, 2 hours more than 153. WHO also endorses the same. ACOG says that you should have a glucose loading test first. If that is abnormal, go in for the OGTT Carpenter-Couston criteria, in which you should have 2 at least. Now the problem here occurs is that you have a lot of pricks required when you go in for ACOG, and the patient has to stay for a longer time. DIPSI, what does DIPSI say? DIPSI says, this is Indian guidelines, 75 gram glucose you give. If more than 140 at the end of 2 hours, it is GDM. More than 120, it is decreased gestational glucose tolerance. So this is again a very simple, feasible, economical type of testing. So if we come back to our case presentation, based on the WHO criteria, fasting was high, GDM was diagnosed. Then what should we do next? Now what should we do next? Let me invite Dr. Firdaus Sheikh, who will tell us what further action should be taken once we have diagnosed. Dr. Firdaus.